The goal of Dr. Nabavizadeh's research is to use imaging biomarkers in prognostication, tumor response evaluation, and differentiation of tumor progression from treatment effects. He has won multiple awards for excellence in his research. He holds editorial positions as a reviewer for renowned journals, and he is also a member of multiple professional and scientific societies. And today he is presenting on molecular imaging in brain tumors.
All right, thank you so much, Raisa, for the nice introduction. I'm really glad to be here with you and presenting on this topic. And I'm going to be talking about molecular imaging of brain metastases. These are my disclosures. And I'm going to be talking about some indications that are not yet FDA approved. So what I'm going to be talking about is that I'm going to be talking about various molecular imaging approaches. However, the main focus would be on amino acid imaging, which has been utilized for a few years and is going to be utilized more and more in brain metastasis. I'm going to show some of the slides to compare various amino acid PET agents and also the clinical indications for PET imaging in patients with brain mets and some of the ongoing efforts. And so in terms of PET imaging for brain tumors, this is a guideline that is quite a few years old. However, this guideline was published in 2019, and the essence of this guideline was that there is an added value of PET imaging when compared to MR, especially when we're using amino acid PET imaging over FDG PET. And this guideline provides a framework for the use of PET imaging to assist us in the management of patients with glioma. However, later there were more publications, not just in glioma, but also in brain metastasis, looking at various aspects of how molecular imaging could help, for example, to determine early treatment response way earlier compared to waiting for months and months for MR to show any change in tumor size, or, for example, differentiation of progression from pseudoprogression and cost effectiveness of these agents when they're added to the armamentarium of patient imaging compared to just doing MRI. And also in the publications regarding investigational PET tracers in neuro-oncology, and some of them are being used in brain metastasis, and also the contribution of PET in terms of how it guides radiotherapy. And finally, we had one paper about specifically dedicated to brain metastasis in terms of what is the current evidence for the utilization of PET imaging in brain metastasis by the PET-RANO group. And so why do we use amino acid PET imaging in brain metastasis? The reason is that amino acid play an important role in many cancers, including brain metastasis. The reason is that the amino acid transporters are overexpressed in these tumors. The two main amino acid transporters that we are interested are LAT1, the gene would be SLC7A5, and ASCT2, the gene would be SLC1A5. There are many more amino acid transporters. However, we are interested in these two because we can image them. And amino acids contribute to cancer cell growth by mediating cell signaling and contributing to tumor growth and tumor survival. And so what is the main reason that we think amino acid PET imaging has a promise? One of the main reasons would be that amino acid PET imaging is not dependent on blood-brain barrier disruption. And we know on MRI, we do contrast-enhanced MRI, and we say that the tumor enhances. And what we mean by that is that these are 5 glioma models in a small animal imaging study, and you can see that these are the different cell lines that were injected into the animals. You can see the tumor growing. Some of these tumors are enhancing, meaning that when you look at the T1 compared to T1 post-gadolinium, you see that the tumor increases its signal in post-contrast MR compared to pre-contrast MR. So these are enhancing tumors. And these are on the top 3, these are non-enhancing tumors, meaning that there is no increase in signal on T1 weighted imaging after injection of contrast. And this is the T1 subtraction, again, dark, meaning that there is no enhancement, and this bright, means the subtraction showed a signal increase. So these are enhancing tumors. But you can see that even in non-enhancing tumors, there has been uptake in PET imaging when we injected amino acid PET imaging, in this case fluciclovine, which is a leucine analog, in patients with show enhancement. It also showed even more increase in signal. So the beauty of amino acid PET imaging is that it is not dependent on blood-brain barrier disruption, and you can still see uptake in the tumors that are not enhancing. So amino acid PET imaging comes in different flavors based on the chemical composition of the amino acid that is labeled. C11 methionine is a methionine analog. The radio and that it's labeled with C11, and the problem with C11 is that the short half-life of 20 minutes makes it difficult to be used in a clinical setting unless the cyclotron is very close to the PET scanner, which is not the case in most centers. And so C11 methionine has been used in limited centers that have this capability. FET PET is a tyrosine analog. It's an F18 compound, so the half-life is 110 minutes, which is great. So it can be utilized widely, and most commonly it has been used in Europe, but it's coming to US, and we're having multiple active trials and expanded access trials that are for larger utilization of this radio tracer. Then we have fluciclovine. It's a leucine analog. The main feature of this radio tracer, which makes it attractive, is that it is FDA approved in prostate cancer, which is a lot more common than brain cancer. And it was used actually for quite a few years before PSMA became the dominant agent for prostate cancer imaging. And so there is a wide network of fluciclovine production in the country, meaning that it can be utilized across the nation for imaging brain metastasis and also other forms of tumor, including gliomas. And finally, F-DOPA is the phenylalanine analog. It's also FDA approved in Parkinson's disease. And so, again, and it's available in multiple academic centers. So it's also another agent that can be used. And so, as I mentioned, the most frequently studied agents are C11 methionine, 18F-FET, and 18F-DOPA. Especially FET has been used widely in Europe. C11 methionine, there's a lot of literature, especially older literature, and it's being replaced mainly by FET in many European countries over the past couple of years or so. And FET has approval in multiple European countries. I mentioned about fluciclovine, that's widely available in the US because it's approved for recurrent prostate cancer. And so in terms of comparing various amino acid PET agents, there has been multiple studies comparing them in terms of the diagnostic accuracy for various indications and also the signal of these radio tracers and the tumor-to-brain ratio and SUVs. And this is a study that compared FET with F-DOPA in high-grade gliomas. Most of these studies are in gliomas, not brain metastases, but basically it serves our purpose of comparing them. And in this comparison, there was no significant difference in uptake pattern of FET and F-DOPA in patients with primary or recurrent high-grade glioma. And you can see examples of MRI, enhancing lesion. And when you do F-DOPA or FET, you can see that the lesion could be analyzed and visualized equally well on both studies. One caveat about F-DOPA is that because there is normal physiological uptake in the lentiform nuclei, if the tumor is adjacent to the lentiform nuclei, then distinction of the border of the tumor and where the tumor ends and where the basal ganglia starts might not be very easy. You can see one case here that the tumor is kind of located posterior to the lentiform nucleus. On FET, there is basically you can see the tumor, and there is nothing adjacent to it to kind of make it difficult to distinguish the tumor versus the lesion structures. But on FDOPA, you can see normal physiological uptake in the lentiform nucleus right next to the tumor, which sometimes could be a problem if you want to measure. However, it can also be an advantage because you also have a physiologic baseline to normalize the tumor too. So in this study, both tumors depicted all the primary and recurrent brain tumors, no significant difference. This is a study that compared FET with C11 methionine in glioma and actually also brain metastasis. And the study showed that there was a strong correlation between two radiotracers. You can see, for example, a tumor in the frontal region enhancing, and you can see significant increased uptake both in methionine PET and FET PET. And another tumor, a multifocal tumor in left parietal and occipital lobe, and you can see that both of the radiotracers show both of the tumors well. So again, in this study, both of the radiotracers differentiated tumor tissue from treatment-related changes. And finally, this is a study that compared fluciclovine with C11 methionine, and they showed that both radiotracers correlate well. And one major difference between fluciclovine and C11 methionine, and also with other radiotracers, other amino acid radiotracers, is that the normal brain uptake is significantly lower in fluciclovine. You can see it here. This is the lesion enhancing multiple, and this is another patient, multiple enhancing lesions in bilateral parietal occipital region. You can see that there is literally very low or zero brain uptake. This is just noise. However, when you look at methionine, you can see that there is measurable brain uptake, which can actually cause a little of problem if the uptake in the tumor is not very high, like equal to the brain, and then it might be difficult to differentiate the tumor from the brain compared to when you're imaging with fluciclovine, that the uptake in the brain is a lot lower, so the lesion stands out in the background of very low uptake. Whether this could have some impact on diagnosis of, let's say, recurrence versus pseudoprogression remains to be determined, but that's an observation that is very clear. So in terms of clinical applications of PET imaging in patients with brain metastasis, there are three main indications per the RANO PET group paper that was published in 2019. The first indication would be identification of newly diagnosed and untreated brain metastasis. The second indication would be to differentiate radiation-induced changes from brain tumor recurrence, so basically treatment-related changes from tumor recurrence, which could present similarly on brain MRI. And finally, and very importantly, the differentiation from treatment-related changes secondary to immunotherapy or targeted therapy from brain tumor recurrence, because these targeted therapies and immunotherapies could cause a pseudoprogression appearance with increasing lesion size and enhancement on MRI. And so, starting with FDG PET is the most widely used PET imaging agent in oncology. The way it works is that the FDG enters the cells through GLUT transporters, and then it gets phosphorylated by hexokinase and then get trapped inside the cells. The problem is that in the brain, there is a significant uptake in normal brain, and that's why it's hard to distinguish a lesion from the brain, especially if the lesion is small, like this one. Once the lesion grows in size, eventually the lesion, especially if it has high uptake, it can declare itself and you can see the lesion on brain MRI. However, in general, it has been shown that FDG has poor sensitivity, as low as 27% for brain metastasis detection, which is not surprising because it's going to miss a lot of small brain metastasis. For amino acid PET, especially FET, has been studied most. The sensitivity is quite high, in the range of about 90%, if the lesion is more than a centimeter in size. However, again, if the lesion is a small sub-centimeter, a third of brain metastasis could be negative on PET. So as a rule of thumb, brain MRI would be the study of choice for diagnosis of brain metastasis before treatment, because MRI is very good in detecting very small brain metastasis, even in the range of 1 or 2 millimeter. They can be detected with MRI, especially when we do volumetric MRI with sub-millimeter resolution. On PET, some of the small lesions are going to be missed. These are a few examples here. You can see this is a study on fluciclovine, but you can see that some of the lesions that are less than 5 millimeter in size, they are missed. You can see them on PET, you can see them clearly on MRI, but not all of them. Some of them are still can be seen. Having said that, sometimes there are small lesions like this one that are easy to miss on MRI, especially if they're located in areas that are adjacent to vascular structures or choroid plexus. And then if you look at the PET, the lesion kind of really declares itself, and it's kind of it's very obvious, like a light bulb. So even though MRI is the study of choice for detection of metastasis, especially the small ones, however, sometimes if you have a PET, concurrent PET, and if you look at it, you can detect some findings that may be easier to detect on PET because the background is very low and the lesion could have a light bulb effect. And so this is an example from Dr. Mike Veronese at the University of Wisconsin using fluciclovine. And you can see that this patient has leptomeningeal enhancement on MRI, which sometimes, for example, this could be subtle on MRI and could be the only location for leptomeningeal enhancement. So I can see how this could be missed on a busy clinical day. However, when you look at the PET, you can see that really the lesion has very high uptake. So you go back, you look at MR, confirm that there's leptomeningeal tumor. And follow-up after 2 months showed a significant increase in leptomeningeal enhancement, indicating diffuse leptomeningeal carcinomatosis. So second indication for using amino acid PET imaging in brain metastasis is differentiation of radiation-induced changes from a brain metastasis recurrence. Again, comparing FDG and amino acid, FDG in studies that have been reported in literature, there is a very wide range from like 40 to 95%. So significant variability. Overall, it's inferior to amino acid PET imaging. A recent meta-analysis that was published last year in the Journal of Nuclear Medicine showed that amino acid PET imaging has a sensitivity and specificity of 82 and 84% for this distinction, brain mets recurrence from radiation-induced changes. And this meta-analysis showed that at this point we have class 2A evidence for the utility of amino acid PET for this indication. And this is one example from Penn that you can see that the patient had a brain metastasis that was resected. However, after 10 months, patients developed enhancement, nodular enhancement at the resection cavity. However, the SUV max was 3.2, which is lower than the threshold that we use. Threshold is 4.7. And so we thought that this is radiation necrosis. And follow-up after 6 months indicated no change in size, confirming the diagnosis. Another tumor, that right cerebellar tumor that was resected. However, after 7 years, you can see that there is a nodular enhancement that was growing over multiple studies in the resection bed. And fluciclovine PET showed a CV max of 5.2, higher than our threshold, and the patient ended up having surgery, which showed 40% tumor and 60% treatment effect, indicating that there is a significant amount of tumor in the resection, in the resected tumor. Another patient from my colleague, Dr. Mike Veronese at the University of Wisconsin, again showing initial presentation in left parietal tumor that was resected. However, after 4 months, there was this nodule at the resection bed growing, and they did flucyclovine PET. This time SUV is very, very high, and this turned out to be predominantly tumor. SUV max was 3.2. And so these are two trials that both of them were completed. You can see that both of them were completed last year, and they're being analyzed and kind of submitted to the FDA to get approval for flucyclovine. And the PURSUE trial was a phase 2 trial that the aim of this trial was to establish the image interpretation criteria for flucyclovine PET in brain metastasis. And then the REVELATE trial was a phase 3 trial that wanted to establish the diagnostic performance based on the threshold that was discovered on phase 2 and to test them in detecting recurrent brain metastasis and differentiating from radiation-induced changes. And so the initial results from the PURSUE trial showed that lesions that have SUV max of more than 4.8 or higher uptake compared to parotid gland should be considered for tumor recurrence. Finally, the third indication for amino acid PET imaging in brain metastasis is a differentiation of treatment-related changes from immunotherapy or targeted therapy from brain metastasis recurrence. So you can see in the example here, the patient on the baseline had two tumors, two brain metastases, which on FET-PET had high uptake. If you look at the color bar, you can see that they have significantly increased uptake compared to compared to post-treatment. And on post-treatment, however, when you look at the MR, you can see that the MR is actually worse. The lesions are larger, the enhancement is not decreased, so everything is worse. And you look at the MR, the edema is worse, the enhancement is worse, lesion size is larger. And so if MR is the only thing that you have, then we just have to say there has been a radiographic progression indicating that the lesions are larger in size. However, when you look at PET, you can see that there has been significant decrease in uptake compared to pre-treatment MRI. And so the studies on this indication mainly came from Germany, Dr. Norbert Galdick's group, and they showed that a threshold of tumor to brain ratio of 1.95 differentiated brain tumor recurrence from treatment-related changes with high accuracy, 85%. And also the metabolic responders, which are patients that the TBR reduced relative to the baseline more than 10% in response to immune checkpoint inhibitors and targeted therapy on FET-PET, they had significantly longer stable follow-up. But again, all these things said, what is the cost of doing amino acid PET for distinguishing recurrent brain metastasis from radiation-induced changes? Because, it might be more accurate than MRI, but what would be the added cost per diagnosis that could be made on PET but cannot be made on MRI? So actually the same group did a study on FET-PET in brain metastasis, and they showed that FET-PET identified 94% of patients with treatment-related changes, which was about 1,600 euros for each correctly identified patients, and also in patients who are non-responders to targeted therapy or immune checkpoint inhibitor therapy. For identifying one additional non-responders by FET-PET, the cost was about 5,700 euros, which is not a small amount of money. However, when you compare this to the yearly cost of immune checkpoint inhibitors, so you have to imagine that a patient is a non-responder and is being kept on immune checkpoint inhibitor that is not effective. That cost is about 30,000 to 100,000 euros per year in Germany. So this study showed that actually this is cost effective because you can detect patients who are non-responders and take them off the drug, which is very expensive with significantly lower cost. So overall, it can reduce healthcare costs by identifying non-responders. So I'm going to shift gears here and talk about immunopet. And this is a term that you may have heard, but basically what immunopet is that it fuses the extraordinary targeting specificity of monoclonal antibodies with the superior sensitivity and resolution of PET in imaging them. So it has been a paradigm shift for molecular imaging modalities, and various immunotracers have been developed to target a wide spectrum of molecules that are expressed in cancer cells and are present in tumor microenvironment. So despite this being very attractive, however, there are challenges. One of the main challenges is that antibodies, they can have slow kinetics, which means that they can clear very slowly from the blood, which means that the background uptake could be high in the blood and also in lymphoid organs, and also the uptake could be heterogeneous in tumors. And so there has been some advances of engineered antibodies. So instead of using a whole intact antibody, they have been engineered to use smaller fragments of them, like mini-bodies and diabodies. And so these tend to have much faster kinetics in terms of getting cleared from the blood pool and also the major organs. And so that's why they have been very useful in some indications. So I'm going to show you some of the examples here, which is this one is a PD and PD-L1 inhibitor. So this is bodies. I'm going to move on to the brain one. So this agent is a PD-L1 imaging agent, and so PD-L1 is a program that ligand 1 is a protein expressed on the surface of some of the cancer cells, and what it does is that it suppresses the immune system by binding to the PD-1 receptor on T cells. So that's why PD-L1 inhibitors could be helpful in some patients with cancer who express PD-L1. And so we need to image the patients to see if the PD-L1 is present. And you can see that this patient with brain metastasis, you can see that the brain metastasis expresses PD-L1. And also on follow-up scan, you can see that the patient developed thyroiditis as a side effect of PD-L1 inhibitor treatment. So this is one example of immunopet imaging. The other one that I'm going to show you is fluoroethyl estradiol PET in estrogen receptor positive breast cancer. And I'll show you three examples. You can see on the first one, patient had multiple brain metastases, one in the left bifrontal region and then the other one in the left cerebellum, that the patient was treated with surgery and radiation. And you can see on follow-up, there has been some increased enhancement in the left frontal region. However, when FES PET was done, there was no significant increased uptake, indicating that this is mainly treatment effect. However, on the left cerebellar metastasis, after radiation, the lesion decreased in size. However, it increased in size again on this MRI, and FES PET imaging showed that there is significant increased uptake, and this lesion ended up being a tumor recurrence. Another patient that had estrogen receptor positive breast cancer, and you can see that there is a parenchymal metastasis showing significant increased uptake, and then also there is leptomeningeal deposits here that they were detected on PET. And finally, this patient had pachymeningeal metastasis in estrogen receptor breast cancer, and FES PET demonstrated significant increased uptake in these pachymeningeal deposits, indicating tumor recurrence. So another PET imaging agent that is important in breast cancer is HER2 PET imaging. And HER2 is a human epidermal growth factor receptor 2, which is a protein that is a very significant player in development and progression of some forms of breast cancer. The problem is that HER2 expression can vary during the course of treatment and also is heterogeneous. Not every breast cancer patients express HER2. And so targeting HER2 with monoclonal antibody it's called trastuzumab, is a well-established therapeutic strategy in HER2-positive breast cancer. And in these patients, HER2 PET imaging could be utilized for serial identification and monitoring of brain metastasis in HER2-positive breast cancer patients. You can see this is gadolinium-enhanced MRI in multiple patients who had brain metastasis from breast cancer that was HER2 positive. You can see these lesions on MRI. So the PET showed that some of these lesions are positive on PET, most of them, but not all of them. Like this one is positive, however, the smaller one, you don't see it. And so this is a less than 5 millimeter lesion, but most of the lesion you can see, but the uptake is heterogeneous. Some of them show more uptake than the others. And they actually did looked at the specimens and did immunohistochemistry and also autoradiography, and they proved that what they see is actually HER2 protein, and this is not just blood-brain barrier disruption and the tracer being present there because of that. This is a tumor-specific binding. And finally, this is a new tracer. It's called PFPN. If you're really interested to know what it is, it's the ethyl aminoethyl fluoroethoxyl picolinamide. Good luck with that name, but let's just call it 18F PFPN. It has high melanin affinity and favorable pharmacokinetic properties. And you can see again patients with brain metastases, one in left parietal lobe, right cerebellum, and you can see that they can be seen on PET imaging. Looking at FDG PET, you can't even see them because there is so much uptake in normal brain. So in a pilot study, this tracer has outperformed traditional FDG in identifying both primary tumors and distant metastasis, which is not surprising. However, it also showed that it can have a role in prognostication. Patients who have high uptake have worse survival. So this is still in the early stages. We have to see how this data will stand the test of time in follow-up studies, but this is exciting kind of preliminary data. And so in conclusion, differentiation of treatment-related changes from tumor recurrence, that's a very big indication in brain metastasis, and amino acid PET imaging is the most thoroughly investigated indication technology for this indication, and more data is coming out. However, having said that, another major indication would be the role of amino acid PET in monitoring immunotherapy and targeted therapy in patients with brain metastasis from solid cancers. Immunopet and target tumor-specific PET imaging is an emerging area. I showed you a few examples, but there is much more work in the pipeline with the new tracers, and this is going to be also an important part of imaging in brain metastasis. And radiologists and the future radiologists should be aware of these efforts and these radio tracers and work closely with their nuclear medicine colleagues to be well informed on this evolving landscape of molecular imaging and PET imaging in brain metastasis. And with that, I would like to thank you for your attention, my lab members and my colleagues both at Penn and CHOP, and happy to take any questions.